Hello. Do you know that it's not every big head that we see after delivery is normal? Yes. Today we want to look at hydrocephalus. But before that, let me test your memory with this question. The question says, while performing physical examination of a newborn baby, which assessment finding should be reported to the physician? Put your answer in the comment section whilst I take you through what hydrocephalus is. Then we come back. Alright, so today our main topic is on hydrocephalus. And when we say hydrocephalus, it comes from two syllables, which is hydro plus cephal. So hydro means water and cephal is talking about the head. So water in the head. But as health professionals, we will not just describe hydrocephalus as what water in the head. And therefore, what is the scholarly definition? So we say it's accumulation of the CSF, which is the cerebral spinal fluid, within the ventricles of the brain, leading to enlargement of the ventricles. Or we can say it is the accumulation of the CSF within the ventricles of the brain, causing these particular ventricles to what? Enlarge, and that puts a lot of pressure on the brain tissues. Now we are talking about, so you see our key words here is the CSF and then the ventricles of the brain. So before we get into details, let's do a little anatomy and physiology of the brain. But this discussion will be centered on the CSF, or the cerebral spinal fluid. So now the ventricles, as you can see, we have two lateral ventricles here, and then we also have the third ventricles here, and then we also have what? The fourth ventricles here. So these are the ventricles within the brain. Now our key issue here is the CSF, the cerebral spinal fluid. This CSF is being produced by the two lateral ventricles. However, the third and the fourth ventricle also produce a small quantity, but majority of the CSF is being produced by the two lateral ventricles. Now within the ventricles there is a cell which is known as the choroid plexus, which is also found within the ventricles. So this thing that I'm mentioning is known as the choroid plexus. They are mainly responsible for the production of the CSF. Now, how is the production like? In each day, they produce CSF in 3 cycles. And in each cycle, they produce about 150 mils, meaning that in a day, about 450 mils of CSF are being produced. Okay, now, what is the function of this CSF? They help to nourish the brain tissues, and then they also help to cushion the brain so that when there's a head trauma, it will not affect the brain tissues. Now we want to look at a condition that occurs when there's accumulation of this fluid within the ventricles. But before that, for us to be able to understand this, then we must first appreciate how CSF is being produced and being flowed or distributed through the brain tissues. So now we want to look at the CSF flow. So first we are saying that the production is being done by the lateral ventricles. Now, when these two lateral ventricles produce the CSF, they are being emptied into the third ventricles and then empty into the fourth ventricles. Now, you can see that there's a connection of the cerebral aqueduct here, which is a duct that also helps to drain the CSF. It has a connection with the third ventricles and also has a connection with the fourth ventricles. And so when the CSF is being produced by the coronary plexus within the lateral ventricles, they first empty into the third ventricle through the foramen of Moro. Okay, so these two ventricles produce it, empty into the foramen of Moro, gets into the third ventricles, and then drain down into the fourth ventricles. Now, because the cerebral aqueduct has a connection with the third ventricles, when it gets there, some now move through the cerebral aqueduct and then get into the subarachnoid space. Now, those that also get to the fourth ventricles also passes through these apertures, which are referred to as the foramen of Lusca, the foramen of Magenda, and then they also empty into the central canal. Then they also get into the subarachnoid space. And so that is the normal circulation of this CSF. Now, apart from that, I also said that they are also being absorbed into the brain tissues, and some are also being absorbed directly into the subarachnoid space without passing through the apertures. Now, how does it do that? You see that at the top here, we have the superior sagittal sinus. This sinus has a connection with the lateral ventricles. And so when some of this fluid, when this CSF is being produced, they are being absorbed to the superior sagittal directly into the subarachnoid space. And then apart from that also, the subarachnoid space also has a projections which are villi. We call it the arachnoid villi. After the production, they also absorb through the arachnoid villi straight into the subarachnoid space. And then when they get to the subarachnoid space, they now drain it down into the spinal cord. And so that is the normal production, the circulation, and the absorption of the CSF. But now we are looking at a condition known as hydrocephalus, where we said it is a condition that occurs when there's a build-up of this fluid within these ventricles, as shown on the screen. And that is what we refer to as hydrocephalus. Now, hydrocephalus can be classified into two main forms. One, depend on the onset. So classification, that is onset, when the hydrocephalus occur. So when we classify it according to the onset, then we can have two types of hydrocephalus, where we have the congenital hydrocephalus, then we also have acquired hydrocephalus. That means that if the baby is born with hydrocephalus, it becomes what? Congenital hydrocephalus. But if the baby is born and maybe had a certain condition like myelomeningocele, and this myelomeningocele, when not well managed, leads to a complication known as hydrocephalus, we call it acquired hydrocephalus. Okay, so when we talk about congenital hydrocephalus, we have 8 causes, and then when we talk about acquired hydrocephalus, also we have also 8 causes. In terms of acquired hydrocephalus, the main cause has to do with what? Myelomeningocele. Okay, myelomeningocele. Then when it comes to the congenital hydrocephalus, the main cause has to do with the cerebral aqueduct here being stenosed, which I will explain later. Then we also said that it can also be classified according to the etiology. hydrocephalus can also be classified according to the cause or the etiology. So under this, we have the non-communicating hydrocephalus, and then we have the communicating hydrocephalus. Now, the non-communicating hydrocephalus means that the CSF being produced here within the lateral ventricles that ideally is supposed to empty it into the third ventricles, get down into the fourth ventricles through to the cerebral aqueduct, pass through the apertures, which are the foramen of Luschka, the foramen of Magendie, and get into the central canal before they get into the subarachnoid space. There is what? A blockage. So if there's an obstruction of any of these ducts, being the cerebral aqueduct, being the fourth ventricle, being the foramen of Luschka, being the foramen of Magendie, it will impede the flow or the circulation of the CSF, and that will lead to what? A non-communicating hydrocephalus. So then when we talk about the communicating hydrocephalus, they are the type of hydrocephalus that occur when the obstruction is outside the ventricles. And so one, we can have an obstruction of the arachnoid villi. We said that the subarachnoid space has a projections, okay, around here that has a direct communication with the ventricles. And so when there's an obstruction of this arachnoid villi, then it means that it cannot drain down into it. And because it is not part of the duct, it becomes what? A communicating hydrocephalus. Or maybe on the surfaces of the subarachnoid space, there is a meningitis that has caused a scarring or scarification on the surface membrane of this subarachnoid space. That means that the CSF cannot be absorbed into the subarachnoid space, and that will lead to what? A communicating hydrocephalus. So, all right, now let's move on to the pathophysiology of hydrocephalus. Now, when we talk about the pathophysiology of hydrocephalus, it mainly depends on three things. Production, circulation, and then absorption. So hydrocephalus means a build-up of cerebrospinal fluid within the ventricles, and we are saying that it occurs when there's a problem with any of this, whether the production is too much, whether the circulation is too much, or there's an issue with the circulation, or there's an issue or problem with the absorption. Now, when we talk about production, I earlier on said that the ventricles are expected to produce about 450 mils of CSF per day. So if there's an excess production, it means that there is going to be a build-up of this CSF within the ventricles, and that will lead to what? Hydrocephalus. Because let's just assume that the 450 mils that are being produced, 150 is being absorbed into the brain tissues, and then 150 also gets to the subarachnoid space, and then the remaining 150 also gets into the spinal cord, and that becomes what? 450. Now we are having a condition, so maybe a condition like a tumor of the choroid plexus, or papilloma of the choroid plexus. That, or maybe there is hyperplasia. Or there is hyperplasia of the choroid plexus. That means that they are going to produce too much of the CSF that the body cannot contain. That means that you will have excess fluid that will not be able to get into the subarachnoid space or the spinal cord, that the spinal cord cannot contain it, and therefore they are going to be built up within the ventricles, and that will lead to what? Enlargement of the ventricles, and the condition is known as what? Hydrocephalus. So that means that one of the causes of hydrocephalus, so now let me put here to be the causes. So the causes of hydrocephalus, under the production, we can say tumor of the choroid plexus or hyperplasia of the choroid plexus. Then 2, when it comes to the circulation, we said that after this fluid are being produced here, they are supposed to pass through the foramen of Moro and then empty into the third ventricles. And so if there's an obstruction of the foramen of Moro, this fluid is going to be built up here, and that will lead to what? Hydrocephalus. So one is obstruction. So when you have obstruction of the foramen of Moro, so we have foramen of Moro, it can lead to a build up of this CSF within the ventricles. Or we also said that when they get into the third ventricles, they empty into the fourth ventricles, but some also get into the cerebral aqueduct before they get into the subarachnoid space. And so when the cerebral aqueduct is also obstructed, it can also lead to what? A backflow of this fluid to the third ventricles and then back to the lateral ventricle. So one of the causes is what? Also obstruction of the cerebral. So 1, 2, obstruction of the cerebral aqueducts. And I said that when it comes to congenital hydrocephalus, this is the main cause of congenital hydrocephalus. Then another one too can also be that the foramen of Luschka is also what? Obstructed, or the foramen of Mangidae is also what? Obstructed. But another cause is also 2, 3 here. That may not be necessary obstruction. We call it anode carry 2 malformation. When the cerebellum, okay, is being displaced, it can also obstruct the flow of the CSF, and that is known as what? Anode carry 2 malformation. When the cerebellum is being displaced, okay, it can also lead to obstruction of the flow of the CSF, and that cerebral displacement is known as what? Anode carry 2 malformation. Then we also have another one that can also obstruct the flow of the circulation, which is Dandy-Walker syndrome. Dandy-Walker syndrome. So all these things can lead to obstruction of the flow of CSF, and that will lead to hydrocephalus. Now, when it comes to the absorption, so all these things I've listed here are for circulation. Okay, so now let's move on to talk about how absorption can also lead to hydrocephalus. So with the absorption, we earlier on said that when the lateral ventricles produce it, some are being absorbed through the sinuses into the superior sagitta, and that means that when there is a scarification, okay, of the sagitta, maybe there is meningitis. So one of the main causes under the obstruction under the absorption, is meningitis. Okay, a chronic meningitis, when there is a scarification of the meninges, specifically the subarachnoid space. That means that the CSF being produced cannot be absorbed directly through the ependyma. Within the ventricles, there are certain thin layers that are found within the ventricles, and that is known as the ependyma. They allow a direct absorption into the subarachnoid space. Okay, and so when the subarachnoid space is scarred because of meningitis, it will also obstruct the absorption into the subarachnoid space or into the brain tissues, and that can also lead to what? Hydrocephalus. So you have the hydrocephalus picture on the screen. Now look at it and let's see how we are going to describe the clinical manifestation. So hydrocephalus, as we said, is just about what? Enlargement of the ventricles of the brain that causes the head to what? Enlarge. So look at the picture and now let's discuss the clinical manifestation. So now looking at the picture, what then do you think will be the clinical features that this baby will show? One, that as we all see, is what? Enlargement of the head. So when you check the head circumference of the baby and it is not within the normal range, you get something like 40 centimeters, it is a sign of hydrocephalus, because a baby should not have a head circumference of what? 40 centimeters. So one of the key features is what? Enlargement of the head circumference. So of the head circumference. Then two, because of the enlargement of the ventricles, it can also cause the fontanelle to what? Bulge. So we have bulging fontanelle. We also have what? Bulging fontanelle. Now, because of the accumulation of fluid within the ventricles, it's also going to cause the lamboidal suture to also what? Wide. So we have widening switches. Now, another thing that we can also see is sunset eyes. Sunset eyes. As you saw on the picture, you see that the eyes of the baby was gazing downward, and that gazing downward of the eyes is known as what? Sunset eyes. Then we also have another clinical feature which is also known as the positive McQueen sign. Positive McQueen sign. Now, how do we elicit this clinical feature? When you do percussion, okay, when you do percussion of the head, you will hear a sound that sounds like a cracking pot. And so the moment we hear that cracking pot sound on percussion, we refer to it as what? Positive McQueen sign. And that is a sign of hydrocephalus. Now, apart from these features, the baby or the child will also exhibit a clinical feature like a high-pitched cry, which sounds like what? A cat. So we have a cat-like cry or a high-pitched cry. Now, apart from these clinical features that we have talked about, one of the main clinical features that the baby will experience is what? Increased intracranial pressure. Now, why this increased intracranial pressure? Remember, we said that there's a fluid built up within the ventricles, okay, and that means that the pressure will what? Increase. And because it is about the cranium, we say it is what? Increased intracranial pressure. Now, when a child or a baby has increased intracranial pressure, what becomes the clinical features? How do you know that this patient is having increased intracranial pressure? One, you have headache, but you need to be mindful as students, because sometimes the question can be that a neonate was assessed to have increased intracranial pressure. The nurse will find these clinical features on assessment, except for neonates you don't expect to see a headache, okay, because they cannot tell you that I have headache. But for a child, okay, a toddler and above, they may be able to say I have what? A headache. So let's be mindful of this particular symptom. Now, apart from the increased ICP that you see, you also see loss of consciousness, okay? The increased intracranial pressure will give rise to headache and also give rise to what? Loss of consciousness or coma. Then, because the ventricles are enlarged because of the excess fluid, this also puts pressure on the brain tissues, therefore distorting the functions of the electrical discharges, and that can also lead to what? Convulsion. That can also lead to what? Convulsion. Now, apart from this, we can also have vomiting. We can also have what? Vomiting. And so increased intracranial pressure will lead to headache, leads to loss of consciousness, leads to what? Convulsion, and also leads to what? Vomiting. Now, so now we are done with the clinical features of hydrocephalus. Now let's look at how we manage this condition. So with the management, first let's look at the medical management of hydrocephalus. Now, how do we manage this condition medically? First, diuretics. Now, because we are looking at fluid buildup, okay, so we can also give diuretics that will help to what? Reduce the excess fluid. And for this diuretics, we can give the thiazides, we can also give the loop of Helen. And the loop of Helen, the main one is what? Furosemide, which will help to drain down the fluid. Then we can also give anticonvulsant. Now, anticonvulsant, because we said because of the pressure being put on the brain tissues by the enlarged ventricles, it can lead to what? Convulsion. So if the child is showing signs of convulsion, we need to give what? Anticonvulsants. Then, apart from this, we can also give antibiotics. Now, the antibiotics, administration of antibiotics will depend on the cause. If it is infection that led to the hydrocephalus, then we can give what? Antibiotic. But if it is congenital and there's no sign of infection, there's no need to give them antibiotics. Okay? All right. Now, let's look at the surgical management. Now, for this condition, the only thing that you can do is to correct it what? Surgically. But then, at that moment when there's a build-up of fluid, okay, what can be done at that moment? All that we need to do is to what? make a shunt, okay, divert the flow of the excess CSF because of the obstruction within the ventricles. And so what surgical interventions are done in order to divert the flow of this CSF? One is VP shunt. That is the ventriculoperitoneal shunt. Okay, so you connect a flexible tube into the ventricles. Okay, remember we say ventriculo. So you connect a flexible tube into the ventricles and direct it into the peritoneum of the child, and then that will help to drain the excess fluid into the peritoneum, and that is known as what? Ventriculoperitoneal shunt. Then we also have another procedure, VA shunt. We also have another procedure that is known as VA shunt, ventricular atrial shunt. So that means that you are connecting the tube into the ventricles down into the right atrium, and then the fluid, the excess CSF, will now drain from the ventricles into the right atrium, and that is known as what? VA shunt, ventricular atrial shunt. So these are the surgical procedures done to correct the hydrocephalus. Okay, so let's come back to our question. We say, while performing a physical examination of a newborn baby, which assessment finding should be reported to the physician? A, head circumference of 40 centimeter, B, chest circumference of 32 centimeter, and then C, acrocyanosis and edema of the scalp, and heart rate of 160, and respiration of what? 40 centimeter. Now, a head circumference that is above 40 centimeter is abnormal. It is not within the normal range. Okay, so that is what needs to be reported because of increased intracranial pressure. Then when you look at it, you say chest circumference of 32 centimeter, that is within the normal range, because the normal range is between the 32 to what? 35 centimeters. So that is normal. Then when you talk about acrocyanosis just means that the palm and the soles of the baby is what? Blue, but other parts of the body looks pink, and that is normal. For acrocyanosis, it does not need any treatment. All that the baby needs is what? Adequate fluid through breastfeeding. And then edema of the scalp could be what? Caput succedaneum, which is not a major clinical effect. Then when you look at the D, it's a heart rate of 160. It's normal. From the normal is what? 110 to what? 160. So that is normal. That don't need to be what? Reported. Then when you have a respiration of what? 40. For a neonate, the normal is what? Between 40 to 60. And so that is also what? Normal. And you don't need to report. But the head circumference of what? 40 centimeter need to be reported. Thank you so much for being with Smartness Tutorial. If you like the video, all that you can do for us is to share and then also give your comments under the video. See you next time. Bye bye.